So let's talk electrolyte balance. So electrolytes are located in the extracellular and intracellular fluids. However, keep in mind that when we draw blood from a patient, we are drawing plasma, we are drawing from that intravascular space, which is extracellular. We can't access each individual area with an IV catheter and or with a blood draw phlebotomy kit. We can only access the intravascular space. And so when we are talking about plasma values, serum values, that's what we're talking about. We're talking about the intravascular, which remember is extracellular. So what you need to know are things that are highlighted within this presentation and on the next few slides: ranges, working knowledge, abnormal values, and then treatment protocols. You will find ATI helpful. You will also find our review session very helpful with this content. So when we need to know what our electrolytes are, what labs do we draw? One of the labs we draw is called a BMP, a basic metabolic panel. And this contains the 5 big electrolytes, also BUN, creatinine, which we'll talk about with kidney, and then also glucose, which comes next week. We also can draw a CMP, which is a complete metabolic panel, and that includes everything that's in the BMP, plus albumin, protein, and then some liver-specific tests. So I tell you this so that you know which lab values to look for when you're trying to investigate your electrolytes. So let's talk about sodium just for a second. The key thing to remember about sodium is that it is married to water. Where sodium goes, water follows, and that is pretty much an absolute rule. It is an abundant cation in the extracellular fluid. It is a major contributor to serum osmolality, and that's why when we talked about fluid shifts, hypo and hypervolemia, sodium kept coming up. It really determines movement of water between the ECF and the ICF. So critical values are 120, 160. We do use aldosterone and ADH to regulate these, and we've talked about that pretty significantly. It also plays a major role in the generation and transmission of nerve impulses, and then we'll talk a little bit about how it combines with chloride to become HCO2. So we do have some specific things that can lead to cause imbalances in that. So hypernatremia, you can see hypernatremia if we have decreased fluid intake, high protein intake, or we're just taking in a lot of sodium and IV fluids. Hyponatremia you can see with fluid losses, so vomiting, diarrhea, hemorrhage, burns, any of those kinds of things. So let's take a look at this. I think this is pretty interesting and a really good way to kind of encapsulate this, and Porth does a really good job. So when you talk about proportionate changes in sodium and water, and we had talked specifically about fluid volume deficit and the difference between that and dehydration. So when we have proportionate changes in sodium and water, so we have a loss of sodium or water leads to isotonic fluid depletion, contraction of fluids in that interstitial and vascular compartments of the ECF. When we have a gain of sodium and water, we have that expansion of fluid in the ECF compartment, and that leads to expansion of fluids in the interstitial and vascular compartments. That's pretty straightforward when they're changing in a proportionate way. When we have disproportionate changes in sodium water, this is where it gets kind of interesting. So when you have the loss of sodium and or the gain of water, you actually have hyponatremia, because that water can dilute the sodium, or you can just have absolute loss of sodium. And that will facilitate movement from extracellular to intracellular. If, however, you gain sodium or you lose water, therefore the sodium appears to be higher, you actually have a state of hypernatremia. And then you'll have movement from intracellular to extracellular. Keep in mind, this part on the right is something you want to come back to and make sure you really have a good understanding of, because it really determines how we manage our patients and what drugs we administer, what IV fluids we administer, etc. Potassium. Potassium is cardiac, cardiac, cardiac. 3.5 to 5, critical value less than 2.5 or 6.5. That is not a lot of variation. So you see how close that scale is, that 3.5 to 5? It's only a 1.5 MEQ per liter difference. Therefore, variation of even only a point is going to make a very big difference. Potassium is primarily regulated by the kidneys. It's a major intracellular cation. This also relates to nerve and muscle impulses, cellular growth, but cardiac is one of the big things, and we're going to talk a little bit in acid-base balance how those hydrogen ions are traded for potassium ions. Remember, the sodium potassium pump also comes into play here because that's going to help control some of that intracellular fluid volume. So we can have hyperkalemia for lots of different reasons. We can have it, you see it very significantly when you have rupture of cell walls, so burn, crush, any kind of trauma, you do see hyperkalemia. If you have impaired renal secretion, excretion, the kidneys regulate potassium. And so if they're not appropriately working, you're going to see an increase in that potassium. And here's a little tip, that if you have a patient that has a super-duper high potassium, we are concerned that this could lead to fatal cardiac rhythms. We may actually put the patient on dialysis, even though they don't have kidney failure, and even though they're not a dialysis patient, if you will. It doesn't matter. That is the ultimate treatment if we need to quickly lower that potassium. And we can get very serious about this very, very quickly. We can also see hypokalemia when you see some abnormal losses via the kidneys. GI tract is an excellent way to lose potassium. If you're having excessive diarrhea, you are losing potassium. You also see that with blood loss. And we also need to watch, some of our drugs can lead to potassium wasting. So when we talk about priorities for potassium, we are really focused on restoring normal balance. We really want the potassium 3.5 to 5. I will tell you that in cardiac patients, because of their sensitivity, their use of potassium, and also in their drug regimen, we generally like to see their potassium in the 4 to 4.2 range. So we don't like them to drift down to 3.5, but for the average person, 3.5 to 5 is normal. So we do need to prevent serious complications, and we do need to treat the underlying cause if we are having variation in potassium. One of the big things that can occur is something called peaked T waves. So we're going to learn about EKG a little bit later, but you'll see that this peaked T wave is abnormal. So this is normally what a T wave should look like, kind of big and broad is how I think about it. I think of P waves as perky and petite, and T waves as big and broad. As soon as you see those peaked T waves, that is a danger situation, primarily related to an increase in potassium. And that is something that is a red flag, that is a huge safety issue. So how do we administer and treat low potassium levels? We can treat it preventatively, meaning if we have a patient who is prone to loss of potassium and or on certain drugs that do that, we'll simply give them potassium in a daily dose. We can also give it PO, and we can give anywhere from 40 to 100 MEQs in 2 to 4 divided doses. However, more commonly than not in the hospital setting, you may see IV potassium administration. It is really important that you recognize that you must know what your hospital policy is regarding this administration. Generally speaking, most drug books are going to tell you no more than 40 MEQs per hour, but hospital policies tend to be anywhere from 10 to 20 MEQs per hour. So what we'll do is we'll take 10 MEQs of potassium, and will be put in a 100 milliliter bag, and it will be run over 1 hour. We never give potassium IV push. We run it very slowly, very cautiously, and we are aware of the site because it can cause burning, discomfort, and we do cardiac monitoring when administering. All really important things to keep in mind. So calcium is regulated by the parathyroid hormone and the kidneys. And so again, it is that feedback system that when we recognize decreased serum calcium, we will actually have trigger in the parathyroid hormone in order to release calcium from the bone, and that will increase the serum calcium. Remember, we do need vitamin D that comes intestine based, and the kidney will actually trigger release of that activated vitamin D in order to facilitate increasing that calcium. So normal calcium level 8.5 to 10.5. We generally do get a lot from our foods, and especially vitamin D. That's why our milk is vitamin D fortified. Calcium is primarily responsible for anything related to nerve impulses. You'll also see some myocardial, blood clotting, teeth and bone, and muscle contractions, but it really is kind of related to a contraction. When I think of calcium, I think contraction. And so when we think about hypocalcemia and we have a low calcium, there are two big things that can occur and two signs that we'll see in our patient. And these are kind of classic hallmark things you'll learn about. So Chvacek's is the one sign, and that's when you kind of tap near over the facial nerve in front of the ear, there's a little twitching that occurs. And then Trousseau's is actually a carpal spasm, and you see that a lot when you inflate a blood pressure cuff. They'll actually have spasmings in their hand. And those are kind of hallmark signs for decreased potassium. So how do we treat potassium? We can give calcium chloride, which only comes IV, or we can give calcium gluconate, which comes either tablets or IV. When we give IV calcium, we really need to watch for blood pressure changes. Because it is related to contraction, if we administer it too quickly, we will see an increase in blood pressure. There's also calcium carbonate, which is why many people take Tums every day and or other supplements. And supplements anywhere from 500 milligrams to 2 grams PO daily, we can give that with some water and watch for some GI upset. We can also give it if they do have hypocalcemia, as I said, we can give it IV, and that's either gluconate or chloride. If they have an increased phosphorus, one of the big things we're going to talk about related to phosphorus is that it has an inverse relationship to calcium. So if they have an increased phosphorus, we actually want to increase their calcium in order to decrease their phosphorus. And so that's why we would administer calcium in light of a hyperphosphatemia. If we have an increased potassium, we can also give some calcium. And again, there is a bit of an inverse relationship there as well. Magnesium is an interesting bird. I tend to think of magnesium as kind of the sister, kind of the annoying sister who's always kind of hanging around. And so when you think about magnesium, you primarily see changes in magnesium when you also see changes in calcium and or particularly potassium. So whenever you're concerned about potassium abnormalities, you generally want to look at the magnesium as well. Now there are certain instances where just the magnesium is off, but for the most part you do see it off in relation to other electrolytes. It is regulated by the kidneys and the GI system. It is contained in bone primarily. And when you think about magnesium, it's really about those relationships. So if you take a look at its functions, it really interacts with all of the electrolytes. So you see a little neuro, you see a little cardiac, you see a little metabolism, and then you see some sodium potassium transport help here. So those are all things to keep in mind in relation to magnesium. So there are some mnemonics, and I included a few more in your soft chalk, but there are some mnemonics for magnesium. And the hyper one is renal, so you can read that there: reflexes, EKG changes, nausea, vomiting, flushed, and lethargy. And then hypo is, you can use the word starved. Now, mnemonics are good and bad, and I mentioned this in the online tutorial. But what I'll tell you is that they do tend to cover a lot of information, and it's very hard to differentiate them. So I'd really prefer that you focused on differentiating what makes magnesium the same as some of the other electrolytes, and what are some of its, differentiating factors that make it different from some of the other electrolytes. And with magnesium, we're really looking at it in relation to other electrolytes. So how do we administer this? We can give a gram IV over an hour. We can put it in 100 milliliters, and we can even mix it with potassium. We can give up to 5 grams IV in about a liter, and then we can also, in preeclampsia or eclampsia, which are OB terms, we use it at that time as well, and you'll learn about that when you get to maternity. We also have some other sources of it, in particular antacids and laxatives, so we do need to keep in mind that those are magnesium based. Phosphorus, 2.5 to 4.5. It is a primary anion in the ICF. Here we see muscle, red blood cell, and nervous system. What's really interesting about phosphorus to me is that we don't really do a whole lot with phosphorus. It's kind of there. It's involved in so many of our underlying systems: ATP, acid base, cellular uptake of glucose, some renal functioning, but it is so ubiquitous in food. We really don't have big issues with our phosphorus. You do need to have a binding agent in order for it to be taken in, and it is measured in millimoles. We can administer it, but again, it needs to have that binding, so we can give Nutriphos, which contains sodium or potassium and phosphorus, and that's what I mean by a binding agent. It has to combine with something else, and we can also administer that IV.